On behalf of Boulder Community Health, I'd like to introduce our speaker, Dr. Jeremiah McNamara. Dr. McNamara is a board-certified obstetrician gynecologist who earned his medical degree from Michigan State University's College of Human Medicine and completed his OB-GYN residency training at the University of Wisconsin. He provides valuable expertise in much-needed GYN surgical specialties such as robotic-assisted surgeries and specializes in a range of treatments to address pelvic floor weakness, prolapse, and associated issues such as pain and incontinence. He sees patients at Boulder Women's Care on the Foothills Hospital campus. Welcome, Dr. McNamara.
Good evening. Thank you, Karen, for that introduction. My name is Jeremiah. Thanks for tuning in. Sam, we can start the slides. So we do have about 45 minutes for me to talk here about endometriosis. I'd like this to feel like a conversation that I have in my office all the time with patients about this very common condition. I wanted to provide you real information but not get too technical and just make it kind of relatable to a real life experience for you all as the patient or people that you know that might have this condition. So I hope I'll get done in about 45 minutes and then take questions, because I think questions can be really valuable about this. In terms of disclosures, I am a consultant for Medtronic, which is a medical device company. I help them develop some of their surgical gizmos. And I am a OB-GYN here at BCH. I and my partners here do see women in pregnancy and deliver babies. And I do also have a special passion and focus on the other part of our job where this topic falls, which is in gynecologic problems and the treatments in the office, out of the office, in the operating room that treat them. And just to admit another little bias of mine as a doctor is that I am very interested in topics and areas like functional or integrative medicine. I study these on my own outside of what I do as an OB-GYN. I really, really believe that there is an important gap that needs to be filled by areas like functional medicine about root causes of problems and lifestyle solutions to problems that are going to come from a different model than the one we're working in with a pill for everything and a surgery for everything. I prescribe a lot of pills and I do a lot of surgeries, but I really believe in a lot that should and can happen before that as being a really important part of all healthcare and disease care. And that definitely relates to endometriosis, which we'll talk about. So I will talk about some functional or integrative angles and solutions to this problem along the way. So just in terms of an agenda, what we'll talk about is, what is endometriosis? What are we talking about? Who does it affect? Why does it arise in the first place? And then what is this experience like to see us about it? How does it get diagnosed? And then importantly, what are the treatments? And I do just want to call attention to the fact that this talk and the way that I will talk about it does refer to the terms women, patients. But I do want to acknowledge that this condition of endometriosis is completely relevant for any human with a uterus. And so I just wanted to acknowledge that. And one other introductory moment I want to take here is just to set a little bit of context, important context about a condition like endometriosis, and take a moment to bash the patriarchy a little bit in that regard. Endometriosis is a really terrible condition that I think is made more terrible by the fact that the medical establishment now, and certainly over the years, has not and continues to not recognize it, pick it up, help patients diagnose it in themselves as much as we could or should. Because it falls into an unfortunate category of problems for women where the disease is invisible and cannot be seen from the outside, and presents with a woman talking to her doctor about pains and suffering that sound like, to a doctor that doesn't really care, just women's problems, you know. And just to kind of tie that into what's on the slide here, and Dr. Freud and his infamous couch, and if anyone has heard the kind of unfortunate etymology of the term hysteria or hysterical women or hysterical people, that comes from this idea, this feeling that was generated around Sigmund Freud and not completely by him, that a person that was being crazy in that way, or a woman that was being crazy in that way at Sigmund Freud's time, was doing so because of something related to her womanness and her womb, which is where the term hysteria comes from. And that is a feeling that still shows up in the treatment of endometriosis, is that I think women, as we'll talk about, definitely have a tremendous delay from when they start to experience symptoms from this condition until they get to an answer, until they get to physicians who I think are listening to them. And it's a problem. So I appreciate people listening and kind of hearing part of a message that's gonna bring this to more light, which it needs to receive. Because indeed, endometriosis is still recognized as a ignored condition. And this, if you look for it, is recognized in the popular media amongst women, amongst younger women and children and teens, where this condition can show up. It is still a major problem that this is diagnosed late and that people suffer for a long time before getting a diagnosis. So, what is endometriosis? I will show you a number of pictures and talk about it in a number of ways, but the idea, the problem at hand, is that there are a certain type of cells that line the inside of the uterus. And in this picture, this triangular pink area within the uterus that makes up the lining of the uterus is comprised of specialized cells that are called endometrial cells. And those cells really are the ones that respond to monthly hormones. They grow, they cause the lining to grow as part of a woman's monthly cycle. And that lining sheds in the form of a period. But those are the cells that do that respond to hormones and cause bleeding. And the condition of endometriosis is one where those cells, those individual endometrial cells, actually get outside of the uterus. They are able to escape the uterus in a certain way, which we'll talk about. And they are able to land somewhere else inside a woman's belly, freely inside her belly, land, survive, and grow slowly over time to create pain and create this problem that is endometriosis. And it is fascinating that it can even happen, but it is true that these cells, these endometrial cells that escape the uterus and land somewhere else in your belly, they are only able to do one thing. They've only ever been able to do one thing, which is respond to your monthly hormones, respond to estrogen primarily. And you could think of it like by the time your period comes and these cells are in the wrong place, you are now having bleeding or you're having your period in your belly, near your bladder, near your colon. And although it is not quite as literal as bleeding into your belly every month, there is a degree of that, and there definitely is inflammation and pain that occurs every month when these cells are activated like that by estrogen. And these deposits, the cells get into your belly, they form these deposits, they survive, they grow slowly over time. They land where gravity allows them to settle down and land, which is generally like the deepest, most gravity-dependent portions of a woman's pelvis, which is really typically right around the uterus, the cervix, the tubes and ovaries, as this picture demonstrates. But it is importantly not just the uterus, and not just the tubes and ovaries. There's other very important things in a woman's pelvis, where these cells settle down and where endometriosis lesions can form. They can form near or on the bladder. They can indeed form near or on all of the female organs like the uterus and the tubes and ovaries. They can form on or near the cervix and the area near the top of the vagina, which can create a whole other set of problems, specifically with intercourse. As that area gets kind of bumped into during intercourse, there can be lesions for endometriosis that are right there. Indeed, that's one of the most common places for it to land. But as this picture shows, it can also show up on your colon, on your rectum, and this can lead to just a host of unfortunate symptoms related to endometriosis. And so I think you could imagine, without understanding all of it, that if you have cells that are creating bleeding in your belly every month for year after year after year of your life, the body has a response to that, which is not good. That is not something that's supposed to be happening in your belly, and the adaptive kind of inflammatory and immune responses of the body to that thing happening are not good. And they lead to this progression where bleeding and byproducts of that lead to inflammation, which does lead to acute pain, but it also leads to the statement that is true that you have a lot of inflammation in your body, that you are chronically inflamed. That is by definition going to be true of someone who has endometriosis. And I think that's kind of a bit of a functional integrative thing to say, but I think that even Western mainstream medicine is getting more and more on board with this idea that an inflamed body, that chronic inflammation is a major problem, not only in the immediate, but with a lot of chronic, long-term, significant diseases. So that leads to inflammation and acute pain. There is a very interesting and unfortunate component of this situation that leads to your immune system also recognizing that there is some problem occurring in your abdomen, which is not supposed to be there. And so you get a large immune system activation, which has a host of other side effects. And as the body does when it's trying to repair damage that's occurring over and over again, you, at the end of this, with endometriosis, aside from the pain, you get the formation of scar tissue and adhesions that can distort normal anatomy in someone's pelvis, that can cause its own problems and pains due to scar tissue and adhesions. And I think perhaps most unfortunately at the end of this is that any human who is exposed to the same painful stimulus in the same place over and over and over and over again will very likely develop true chronic neuropathic, as we say, like nerve pain and chronic pain syndromes. And it's tragic that this even exists as a thing, but it is true that chronic pain can develop from something like endometriosis. And it can be that with all things that are in this category, you can very often even remove the initial stimulus that's causing the pain, and the pain persists because it's really just your nerves that can't forget the pain. So that occurs with endometriosis for sure, and is tragic indeed. So just to get literal about this, the definition is that it's endometrial cells and glands and stroma that get outside the uterine cavity. It is an estrogen dependent condition. So I use the term female hormones, but it's really true that estrogen is the primary driver of stimulating endometrial cells and causing this whole problem to go forward. So it is estrogen dependent. It is benign. There is a very small connection and discussion around, is this related to cancer? Could it be related to cancer? And I think the real basic truth of that is that it's not. This is a benign condition that can cause a bunch of problems, but developing into cancer is really not one of them, thankfully. And as we've said, it is a condition that has a tremendous amount of inflammation and immune system activation that goes with it. It is unfortunately chronic in the true sense of the word. It is really not immediately curable. There's not a pill for this, nor is there a surgery that just takes it away. It is a process that starts and propagates, and we do our best to get control of it, but it is truly chronic, and we'll talk a little bit more about that. And it indeed can affect many spheres of a patient's life. You know, this, as chronic pain can do, that pain follows you everywhere. It exists at home and your relationships at home. It exists at work and how you function in the world. It has a lot to do with sex and intimacy. It has a lot to do with fertility and growing your family. So it has a tremendous impact, is the truth. And so I'll show some other pictures later when we kind of talk about like the surgery. What does this look like? What are we dealing with? But, you know, these spots that I was referring to, these implants of endometriosis, they obviously can range from just a few to an awful lot. And anyone listening that has endometriosis or that knows someone that has looked into this is probably aware that this comes in a lot of different varieties and stages of severity. So stages do get talked about in the diagnosis of endometriosis, which, as I said, kind of starts with individual lesions, and as this gets more advanced, we get lots of lesions and we get scar tissue, we get adhesions, amongst other things, in the belly, along with a certain type of ovarian cyst that develops with endometriosis, which are called endometriomas. And this is, I think, just an item of knowledge for everyone, is that there is, you know, as gynecologists, we talk an awful lot about ovarian cysts. There's a lot of ovarian cysts in the world, and we find them on ultrasound either accidentally or on purpose, and we try to figure out what's going on. And there is a particular type of ovarian cyst that goes along with endometriosis. It's called an endometrioma at the top of that slide, which has a very particular physiology to it. It is filled with a very particular substance, which is kind of this like dark brown bloody material, which ends up having these being called chocolate cysts, which is kind of a strange term. But they have this ground glass appearance on ultrasound. And so this is one of very few things, which we'll touch on, that it can actually be almost diagnostic of endometriosis on an ultrasound. As if we see something that really, really looks like an endometrioma, then we can get quite close to making the diagnosis without doing a surgery. But many of these other implants and adhesions and everything else that I talked about in terms of the disease is really not visible on imaging tests, which is something that we'll talk about. That makes endometriosis very difficult to diagnose. And so we will touch on this a little bit later as well. But another distinction that's, I think, important for patients with endometriosis to understand, and it definitely affects how we talk about surgery, is that the initial lesions, the initial colonies that start with endometriosis are going to be superficial, as we say. And so in the bolded area in the top left of this slide that says superficial peritoneal endometriosis is how this is always going to start. There's a cell that's just going to land over there, and it's going to grow, and it's going to be sitting right on top. It's going to be very accessible. It can cause a bunch of problems, but it is superficial. It's sitting right there. There is a more advanced stage of endometriosis that can occur after more and more time has gone along, which is called deep infiltrating endometriosis, which is here at the title of this slide, which is where those initially superficial cells can start to kind of burrow in deeper into deeper layers of your anatomy in your belly. And so that can be into anything. That can be into the uterus, it can be into the wall of the bladder, it can be into the wall of the colon. And also the rectovaginal septum is an important place where deep infiltrating endometriosis occurs. This picture in the lower right, which I'm sure looks quite strange, is a description of the fact that endometriosis can really get into these places that are hard to address surgically. That, you know, that's really like the posterior wall of the vagina that has endometriosis in it, which it can create a tremendous amount of pain with intercourse and other issues. So the main symptoms, let's just talk about that. Like, what symptoms are we talking about? There are four primarily. They are painful periods, painful intercourse, bowel and GI issues, and then infertility. And there are some fascinating other ways that endometriosis can show up just as a problem. You know, if you have endometriosis and endometrial cells that can actually travel to other distant parts of your body, like your lungs, like your brain. It can feel and act a lot like a metastatic cancer. And then all of a sudden you have these really rare but crazy situations where someone gets their period every month and they have blood in their lungs. So these are really like odd and perplexing problems that can occur. But just to talk about the primary most common symptoms. So this is a study that was done about 1,000 women that were known ultimately by a surgery to have endometriosis, and looking back and what symptoms did they present with. So just a description of that. In this particular study, group 1A, in the first column, they had mild disease, stage 1, stage 2. Group 2, second column, had more severe disease, stage 3, stage 4. And then the totals, which I just circled there, kind of just talk, what is circled are the percentages of women who presented with that symptom. So dysmenorrhea, painful periods, most common presenting symptom. Generalized pelvic pain that's not related to a woman's cycle, also very, very common, 70% of this group of 1,000 women who have endometriosis. Painful intercourse was present in half. So I think this is important just for patients to hear who are thinking about themselves. Half of women, I think some people might hear painful intercourse and they might not have that. And I don't want there to be a message here that you don't or can't have endometriosis if you don't have some of these symptoms. So indeed, half of women in this study that had confirmed endometriosis did not have any pain with intercourse, but half did. Functional bowel problems like constipation and diarrhea was present in a third, bowel pain in a third, infertility was present in 26% of the study. Ovarian cysts or masses or tumors like we're talking about. Dysuria is a term for painful peeing or like kind of discomfort when you're voiding, and other urinary problems. So I just wanted to kind of put those symptoms out there. And just to touch on this relationship to infertility, which is really forefront on people's minds as in the clinic when they're asking about this, is that endometriosis does have a significant relationship with infertility, which indeed is one of the most kind of worrisome aspects of it. And it is one of the most common causes of infertility. As many as 50% of infertility cases may ultimately have endometriosis discovered. And then when you kind of talk about that in a different way, and when you take a group of women who have endometriosis, 30 to 40% of them will experience fertility problems. So a lot in both cases. And the mechanism for that, may be, we don't fully understand the mechanism for that, but I think it's reasonable to guess that one, adhesions that are physically altering the ovaries and the tubes, which need to be anatomically normal to catch the egg and for pregnancy to happen, that those can be distorted and kind of messed up with scar tissue with endometriosis. And then there are a number of other kind of like inflammatory cytokines and like mediators and chemical substances that are occurring in the bellies of women who have endometriosis, which I think the scientific geeks would describe as hostile to the egg and the sperm in the pregnancy process. So it is a problem for fertility. And just to kind of touch on this question of is endometriosis related to cancer? What is my risk of developing cancer because I have this? And this large study that talked about the association of gynecologic cancers and endometriosis, really ultimately the one thing that may have come to light a little bit is the idea of a risk of certain types of ovarian cancer. But this is one of those things where 2 excess cases per 1,000 patients that were followed for 10 years, it is a risk. It's a very small risk in the grand scheme of things. So I want to kind of acknowledge perhaps a kernel of truth there, but I don't want patients with endometriosis to worry excessively about developing cancer because I think that risk is really low. So who does endometriosis affect? It is a condition that's typically diagnosed in a woman's 20s and 30s. Although, as that point notes at the bottom, this is diagnosed not early enough and not enough at all. And those women who are diagnosed in their 20s were very, very often having symptoms from their teens. And so the peak incidence talks about when we actually get the diagnosis right. And indeed, a lot of women, as I said, suffer for a long time before getting that diagnosis. The larger statistics are about 1 in 10 women and girls in the United States, so 10% of all women might suffer from this. And when you look at a group of women who have chronic pelvic pain, that number is as much as 70% of women who have chronic pelvic pain. 70% will have endometriosis, which is huge, a huge cause of chronic pain. Big numbers worldwide, and as I said, these are definitely an underestimation. There's no way that's not true, because it is not diagnosed enough and it's not diagnosed early enough. And when this has been studied, as many as 10 years go by from when patients start to develop symptoms to when they actually get a diagnosis. What might increase someone's risk for developing endometriosis? It is true and good to know that a positive family history is a real thing with endometriosis. There are genetic factors that are involved here. Twin studies suggest that twins correlate in having a higher shared incidence of this, and having first-degree relatives that have endometriosis is real. And so if this exists in one's family, it is good and important to recognize that, even if someone doesn't have symptoms or they're not kind of clear about their symptoms, that is really real. And anything else that has, I think you could tell the story of not allowed a woman to have a break from having periods, which nulliparity refers to just not having yet had kids, or prolonged exposure to endogenous estrogen, as in periods that started early and ended late, so early menarche and late menopause. Short menstrual cycles probably correlates to women who are not ovulating regularly, which is something that we'll get to in a second. Heavy bleeding, obstruction of menstrual outflow, we'll talk about in a second too. That's a rare situation where kind of menstrual blood is not able to get out, and so it has a tendency to go back the other way and kind of get into the belly and cause this problem. And there are some toxic exposures and other kind of biometric risk factors. Reduced risk are things that give women a break in a way from periods and the estrogen exposure in periods. And so that's being pregnant multiple times, having extended intervals of breastfeeding where you're not having your period usually during that time, and then kind of having your period start late. So something I just talked about there is I think the correct leading theory about how this actually happens. Why does it arise? And that is the idea of retrograde menstruation. So this will sound crazy to people if you've never thought about this idea or heard about it, but when a woman has her period and there is blood in the endometrial cavity, it is indeed possible and very common for that blood to actually go the wrong way out through the tubes and get into the belly. So that's called retrograde menstrual bleeding. And that would make sense that that's how you can get endometrial cells into your belly. And that I do believe that's how they get there, and that's kind of the leading theory. But it doesn't explain the whole thing, because retrograde menstruation, it's been estimated to occur in 90% of women. So, and 90% of women don't have endometriosis, only 10% do. So there's something else that's occurring here that's providing the landing environment for these cells to grow and persist. So continuing on, why does it arise? It is indeed, I think, a multifactorial problem. I think retrograde menstruation is one of the first factors. But that includes altered immunity, imbalanced cell proliferation, and apoptosis, which gets into some of the genetics that are mentioned in that second paragraph, aberrant endocrine signaling, and genetic factors, as we've already talked about. And indeed, I think something that's very interesting and I think perhaps a little worrisome about endometriosis is that it has these parts of its story that sound akin to cancer. I mean, indeed, this is a process where cells are getting somewhere where they're not supposed to be, and they're propagating kind of on their own in a way that's escaping some amount of control, which obviously sounds a little bit like cancer. And indeed, cancer driver genes like those that are listed there have been associated with endometriosis. And endometriosis cells also have been shown to have this creepy cancer-like ability to actually generate more of their own estrogen and feed themselves to propagate themselves, which obviously doesn't sound very good. So it is more complicated than just retrograde menstruation. And there's just a lot more at play there. So retrograde menstruation, yes. Genetics, yes. Epigenetics, in terms of, our genes are not our entire story. And the experience of ourselves as early as in utero, and then the environment that we live after we're out of the womb, indeed has the ability to affect our genes and our gene expression. And so epigenetics gets to that idea, which has also been implicated in endometriosis. And then, as I mentioned before, there is something else going on here about the environment inside the body that allows this process to happen, because it's not just the retrograde menstruation. And so I think the functional group would suggest that estrogen excess or estrogen dominance is playing a role here. There is an undeniable connection between estrogen and endometriosis, fueling it. And there is definitely an association between patients who have this condition of estrogen dominance and endometriosis. But there's also other baseline states of chronic inflammation and chronic immune system activation and toxicity that probably are contributing to give rise to an environment where estrogen either is able to start or it's able to survive after it starts. And so this is an area where I believe the functional medicine angle is helpful. When we try to think about, functional medicine tries to think about root causes. I love conventional medicine, but we don't talk about that in the office when you come to talk to us about endometriosis. We don't have anything to say about really why it started, other than there is a genetic component and you have it. So let's move on to the treatments. And that I think that's fine in some ways, but it's also like agnostic of a ton of important, interesting things, like why it occurred in the first place. And as I said, estrogen dominance, an environment of inflammation and immune system activation or dysregulation are really probably important parts of this. And where functional medicine I think is useful here is that, as we'll see in a sec, like the mainstream medical treatments for endometriosis are related to estrogen and reducing one's estrogen, either with birth control pills and kind of controlling it, or getting on these medicines that throw you into menopause and really drop your estrogen levels so it doesn't stimulate your endometriosis. So there is an estrogen problem here, and it would make sense that estrogen dominance, if that is the thing, is feeding this problem. And so I think it's useful just as a teaser or just to put this idea out there that I believe estrogen dominance is real. And this is something that you can investigate to start with yourself and then to try to, complement what you're getting from your traditional OB-GYN with a practitioner that talks about this kind of stuff, because I do think that there's important solutions that exist in this conversation of why do I have too much estrogen or an imbalance of estrogen between estrogen and progesterone. And so just to say this quickly, that the idea of estrogen dominance is that not that someone necessarily has tons and tons and tons of estrogen, although increased estrogen I do think is part of the problem, but it is at its core an imbalance of progesterone to estrogen, and that you really don't have enough progesterone to match the levels of estrogen that you have. It leads to a situation of estrogen dominance and its attendant problems. So why might a woman have increased estrogen in her body? Drinking alcohol, sugary and starchy foods have all been implicated in higher estrogen levels in women. Obesity in men and women, our adipose tissue, all of us, generates estrogen. This is true for men and women. And so obesity will every time have higher levels of estrogen that go along with our increasing BMI and body fat. PCOS is a condition, one of chronic ovulation does lead to higher estrogen levels. And then there's also, you either have too much estrogen that's joining the party or you're not getting rid of the estrogen that you have. And so that idea gets to the one of detoxification or excreting estrogen, because it does get produced and it does need to leave your body. And so the ways in which that can go wrong for people has to do with their liver, and that liver dysfunction can lead to detoxification issues, and that you can't detoxify your body of estrogen, leading to dominance. Or gut dysfunction leads to a very fascinating and concerning problem of women trying to excrete estrogen into their bowel, which is how you're supposed to get rid of it, is by pooping it out. And due to gut dysfunction, you end up reabsorbing all the estrogen that's in your colon and recycling it, and thus leading to dominance. And then an equal part of this problem is not having enough progesterone. And so the main way that women do get progesterone ever is from ovulating. And if there are conditions in life where women are not ovulating, that will lead to lower progesterone. It will lead to estrogen dominance. So the leading cause of not ovulating, just to talk about it in very plain terms, is stress. Is physiologic, physical, emotional stress. That might sound like voodoo to people, perhaps, but that is the truth. And I think that's actually the lived experience of a million women out there, is that stress can have a major effect on your hormones in your period and can lead to not ovulating and can lead to low progesterone, which leads to estrogen dominance. So there is a component there of stress, unfortunately, which is a hard problem to fix. So how do we diagnose it? This is to step back into the mainstream medical office here. A good history is critical. Like, the story is very important here. You know, all painful periods are not the same. There are certain parts of a woman's story that are really important for us to listen and hear, to give us clues that we're talking about endometriosis. A physical exam in the office is helpful. There are definitely some telltale findings on a physical exam that can tell us that a woman might be suffering from this. One major thing to say here is that imaging, this next bullet point, one of the major problems with endo, and the reason that it's difficult to diagnose and underdiagnosed, is that it is essentially invisible on imaging tests, which is a problem. So these colonies are microscopic initially, and then even when they're causing tons of problems, are very small and they're flat, and you can't see them on an imaging test. The only way we're really able to actually see them the vast majority of the time is when we're actually doing surgery and we can see them with our eyes. But the fact that we can't pick this up with an ultrasound or an MRI is a big problem with endometriosis. It doesn't mean we don't do them. We try to get the information that we can get, but they don't get us the diagnosis. They don't really always tell us the truth. Another good question is, are labs useful? Is there something else we can be checking here? Is there a tumor marker? Is there a serum marker that tells us that we have endometriosis? And the answer is unfortunately no to that. It has certainly been studied, and there are different markers that have been looked at, but there is not a reliable blood test to say whether or not you have endometriosis. There are really inspiring studies that are going on about microRNA that's collected. These tests are collected through saliva samples, which have been shown in these early stages to be extremely accurate at diagnosing endometriosis and byproducts that are present in the saliva. So I think we might experience some wins in this category as we go in our lifetimes. But the two other real ways that we actually get closer to a diagnosis in those last 2 points is either choosing to do a surgery and seeing it, biopsying it, and then diagnosing it for sure, because that ultimately is the only way we really know for sure. But the other option is perhaps we don't choose to do that right off the bat or ever, and we say the story sounds enough like endometriosis. Here are the treatments that are available for endometriosis from a medical perspective, by regulating your hormones, by some of these lifestyle interventions. So we empirically try the medical treatments and then see if we have success. And while that doesn't confirm the diagnosis in the real way, it certainly is a way to really get very close for a lot of people. And good docs have to be very careful not to get hyper-focused on endometriosis if that's their thing, because there are definitely other causes that can cause a similar constellation of symptoms. So what do we do about it? Treatments for endometriosis, as the ASRM comments there, we really need to think about how to maximize the use of medical treatments, lifestyle interventions, and not rely on surgery over and over for this problem. But that does not mean that surgery is not very, very important for a lot of women who are dealing with endometriosis, because it is. But this is a balancing act between medical and surgical intervention. And there's very smart people in our field who believe that medical intervention should really kind of be the way, and we should really lean very heavily on that. And there's very smart people in our field who think that surgery is the way, and that medicines have a role, but that good surgery is kind of where the success is within endometriosis. And I think, as with all things, it's probably somewhere in the middle. So to go through treatments for endometriosis, let's start like way down at the end of the intervention scale, as in, what if we don't do anything at all? And there have been a few studies that look at this. What is the natural progression? What's the natural history of endometriosis? And this particular study, which it seems weird that you could even do a study like this, looked at women who did have a laparoscopy, had a diagnosis of endometriosis, actually didn't have any treatment done at that time, and then had a second look laparoscopy 6 to 12 months later. And this is interesting and maybe in a way hopeful, I think, for patients, in that you can see these numbers about what percentage of those women progressed in their disease, regressed in their disease, or remained stable. And it's kind of like in thirds, a third in each of those categories. Which I do think is a point for hope and encouragement that not all disease progresses. And indeed, we talk to patients about whether or not they need to be on hormones forever, or I just had a surgery, do I have to go on suppression afterwards in terms of hormones? And we talk about data like this, like, must you? No, and we don't know always what's going to happen. And if we alter some of the rest of the story from kind of a functional lifestyle perspective, can we push ourselves into this stable or regression category? Which I don't know the answer to that, but I would hope the answer is yes. So what I was just mentioning there, how do we push ourselves into a better spot in a lifestyle way? So this is kind of continuing to bump up the intervention chain. Do nothing. I think functional medicine and integrative medicine probably offer a good view on even the pre-medicine part, the lifestyle approaches. And as we've talked about, there are really two problems here. There's the endometriosis, and then there's your body's response to the endometriosis. And if we have any ability to alter or to support our body's ability to deal with inflammation, our capacity for that, or to help regulate our immune system, and we don't have perfect ability to do that, but we do have some. I think we have more than mainstream medicine would have you believe sometimes. If we can alter those things, then we can change the experience of endometriosis. And so our goals should be to support our bodies and our ability to deal with inflammation in our immune system, and then also don't add any more fuel to the fire in terms of extra estrogen or other sources of inflammation. So what do we do to support that? Whole lectures could be given on each of these topics, but as you can see in that list of supportive practices, less stress, more nourishment, better sleep should be number one for every single thing that has to do with human health. Number two, parasympathetic practices like mindfulness and relaxation practices are very important. There is something about a sympathetically driven, stressed body that creates this environment where endometriosis has a chance to thrive. Excellent gut health is a big topic, but as we talked about, there are problems in here that come from an unhealthy gut. And then there are some supplements which can be helpful for this. Out of all the things in that list, supplements are always going to be bottom. There are foundational practices which need to be addressed first. And then things to avoid: stress. That's a big comment, but there it is. Inflammatory foods, environmental toxins, and blood sugar spikes are all things that have the ability to increase our immune and inflammatory responses. And there have, thankfully now, been more and more studies about the effect of diets, and I'm not connected to gluten-free or anything free, but it is an important investigation for people to be thoughtful about things in their diet that are that they are reacting to, because you are having an immune inflammatory reaction to foods that you are sensitive to. And that is, I think, a really important breeding ground for this inflammation that kind of can be part of the problem. And I wanted to just throw this out there, this idea of an unhealthy gut and estrogen dominance as it relates to estrogen recycling, like I was saying. The way that a healthy female system excretes estrogen and thus does not have estrogen dominance is that that estrogen gets processed by the liver, it gets put into the gut, and then it needs to be excreted through the gut, through stool. And if the body has dysbiosis, if it has an inflamed, unhealthy, leaky gut, your colon, your gut loses the ability to detoxify, to package and get rid of the estrogen. And what happens is that your body then reabsorbs it out of your colon straight up back into your system. And so you have way more estrogen going back in, and you are still making it at the same rate, but you have way more. You have now have estrogen dominance because you have an inability to excrete estrogen. So I just believe in this, that the gut problems can have major other effects. And it just catches my attention as this is a real example of that. I think sometimes you hear that from people and you're like, I don't know if my gut has anything to do with that. And this is a very discrete way that gut dysfunction can lead to estrogen dominance. And so, I think a very good question from people is, all right, diet, good. What is it that we can look at or try in terms of diets that helps with this? And I would not say that there's a diet that solves endometriosis by any means. But if there is one that's going to work, it's going to be one that's low inflammation and low inflammation for you. And so that is, for everyone, is going to involve a lot of fruits and vegetables. And I think eating organic, and I'm not tied to that for some other reason, but I do think it helps you avoid other toxins. I think that is going to be true about organic food. And then the second bullet point there is that what's probably more important is to get curious about foods that you're not reacting to well, and to not ignore that any longer. Like, I think a lot of us have some of that, and this is not an instruction to cut everything out of your diet, but think about this. Spend some time looking at this, or talk to a doctor who can help you with this if those GI symptoms are there. And then I will kind of just put these supplements there. There are, when I listen to podcasts and hear talks about things, I want to know what the supplements are that are relevant. The instruction is not to rely on supplements and think that that's going to solve the problem. But each of these does support our body's ability to deal with inflammation, and to deal with the root cause of this problem. And so, each of those supplements does have verifiable success in terms of the symptoms of endometriosis, not the root cause. And I do think it's important to just note that cannabis has an increasing amount of attention for lots of things, I suppose, these days, but it definitely is gaining more and more attention and has legitimate study about pain and about inflammatory pain, and especially about immunoinflammatory pain. And I think we're going to see more and more very interesting data about cannabis, not just THC, but CBD and THC as it relates to endometriosis, as it relates to just dysmenorrhea and other women's health issues. So the medical management, so we talked about do nothing, lifestyle, these are the medicines, and then we're going to talk about the surgery. And the medicines here, I don't want to spend too much time getting in the weeds about mechanisms, but there are definitely medicines that work for the treatment of endometriosis. We do have a bit of a progression in terms of how we talk about it. The first line agents there all really have the idea of, all right, can we regulate the amount of estrogen that's there? Can we control it in some way to improve the situation? Not eliminate estrogen, but regulate it. NSAIDs actually is not really regulating estrogen. That's just dealing with inflammation, but that's part of our first line regimen. Birth control pills or which are typically estrogen and progesterone, or progesterone only options like the mini pill, like the birth control shot, which is progesterone only. There are a number of ways to use what are all hormonal treatments to regulate your estrogen levels, which can definitely improve pain and symptoms from endometriosis, hard stop. So I know not everyone wants to be on more hormones, but this is an effective treatment for what's going on with this problem. And there is indeed a role for hormone-releasing IUDs like Mirena and Skyla, in so much that those IUDs do not give a lot of progesterone to the body. It's part of the reason that they're kind of attractive just for normal contraception, is that they really act locally and not very much systemic absorption, but they do suppress your period in a way that's really quite a gift for women who have endometriosis and really, really terrible periods. So a discussion of NSAIDs around the time of your period and birth control pills in some variety is usually the first part of the conversation. The next step, which is either a next step or it's where we go first for women who are really miserable or who really are not interested in taking birth control pills or perhaps can't, is that there is this next group of drugs which are not going to try to regulate estrogen, but really knock it down, really suppress estrogen. And these are GnRH agonists or antagonists, which we don't need to spend too much time on, but you can either, on that picture on the right, you can either directly affect estrogen levels there at the bottom of that picture, or you can go higher upstream and stop the signals that are leading to your ovaries producing more estrogen in the first place. And that's what GnRH agonists and antagonists do. So these are definitely effective as well. They're really very effective, but they have some unpleasant side effects that can feel a little bit like menopause, as you might imagine if your estrogen levels are being dropped significantly. There is safe, effective ways to mitigate those menopausal side effects. And so GnRH agonists can be super effective and they can occur without those side effects. Like, it's an important message to patients, is that I think these medicines can sound bad, but you can have a normal side effect free or minimal side effect experience with them. And then there are some other last line treatments. And then it is also just important to mention that if there is a neuropathic or a chronic pain component to these presentations, then we do have other medicines that are non-hormonal altogether that are just treating nerve pain and chronic nerve pain. We also have special kind of tactics for pelvic floor pain, and myalgia is the term for painful pelvic floors. And then ketamine infusions have a lot of interesting data around neuropathic chronic pain as well. So this is an important conversation to have with your doctor about how to think about this algorithm, where to start, where do you want to start as the patient, and to go through that. So the last thing we're going to talk about in our remaining time is about surgery. And so, this is the part where it's, I want to kind of do this in a way that's very similar to how patients talk to me in the office about these surgeries, because I do a lot of these. So we're going to go through just some common questions about this. How do we decide to do it? What are we doing? What's the success of it? Because surgery is an important part of this. So how do we decide to do surgery is that not everyone needs to go through some organized set of steps in this process. I think as an ethos, a lot of doctors will often kind of present these options in a way that ranges from the lowest intervention, safest options, up to the higher intervention options. And surgery is certainly at the higher end of the intervention scale. But, endometriosis, as we've talked about, is a chronic condition that many of my patients have had for years and have suffered for years before they even come in and talk to me. And many patients, for various reasons, whether it's related to pregnancies, whether it's related to how they've done on hormones in the past and whether or not they want to take any more hormones, have different feelings about taking birth control pills and having that be the first thing that we start with. So I do think a good doctor will meet you where you are in this experience and will give you the best options, and you can decide where to go. And I think for a lot of patients, it's very reasonable to go straight up that progression, control what we can in a lifestyle, try the medicines that make sense to us, only use surgery if we need to. Or there are some patients who don't want to go in that order for one reason or another. And that for them, having a diagnostic surgery, getting the answer, knowing what we're up against, treating the endometriosis during surgery, and then making a decision about what we do after that, hormones or not, that's the right way for them. And there's nothing wrong with that progression either. So it is different patient to patient, and it should always be customized on someone's experience, their history, and where they're at with this. So what is the surgery and what are we doing during it? You know, the surgery itself, it's a laparoscopy. These are done laparoscopically, meaning, and you know, this is the technique that we use to do almost everything in gynecology and even other surgeries these days. Very small 5mm incisions, one in your belly button, which will be very difficult to ever find that one again, and then usually 2 and 3 on the sides. And the idea is that this is truly, in the first sense, diagnostic. We're just putting a camera in your belly to see what we see, to see if we see endometriosis. And seeing it and diagnosing it is step one, and looking very carefully for all the places it might be. Treating it, removing it, and actually doing the treatment of it is a second part of these surgeries. But this is an outpatient surgery. These are about 30 minutes long. They can range depending on how much endometriosis is there, but they are shorter. They are outpatient, and they have small incisions and typically pretty quick recoveries, although this is variable, as I said, depending on how much disease someone has in their belly. And so it may or may not be interesting for people to see endometriosis lesions, but it does provide some kind of context to the whole thing, is that these are frustratingly small lesions, little brown, black spots, and scar tissue, contracted scar tissue associated with them, that is the root of a tremendous amount of pain and suffering, but they can be really quite small. But these are sometimes called powder burn lesions. They're just these smatterings of small, dark spots. And they can exist anywhere in the pelvis, anywhere in the belly. And they are these, as that picture shows, these superficial, initially, dark spots, which we see, we take pictures of, we biopsy them and get it right, and then treat everything that we can see. It is important to, as it is with all surgery, work with a surgeon who does this and knows what they're looking for, because not all endometriosis looks the same. And that picture in the lower right is what we are typically taught in med school is what endometriosis looks like, these powder burn lesions, these kind of like dark, scarred spots. But endometriosis can actually have a number of appearances, and it can be really tricky sometimes to diagnose it accurately and treat it in its entirety, because it can be black, it can be white in color, it can be yellow or brown, it can have this like pustular clear appearance to it. It can be red, and it can have these other like kind of scar tissue-ish peritoneal defects. And so, you know, many other pictures about endo, it's obviously a super heterogeneous group of lesions that we find inside, but you know, what we do up front is just a diagnostic surgery to see what we see, to get the tissue diagnosis, to know what we're up against, and then to treat everything that's there. And just a couple points about this to finish the conversation about surgery. One, in the upper left, it is incredible to me all the time about how poor a correlation there is between the amount of endometriosis I see in someone's belly and how crazy miserable their symptoms were. Those two things do not correlate as much as you might think. You can have a very clinically, visibly small amount of endometriosis that creates a tremendous amount of pain and suffering. And some women have terrible endometriosis visually, and have really minimal symptoms, or indeed are sometimes asymptomatic with really bad looking disease. So there is even more complexity in there that we don't understand. One important thing to touch on, which you will talk to your surgeon about, is that what do we do with the endometriosis when we find it during surgery? We either excise it, we very carefully cut it out, which might sound kind of intense, but that's a pretty delicate, just removing the superficial endometriosis. So excising it or ablating it refers to using heat and energy just to very superficially burn these lesions and destroy them. So those are both very effective, and they're actually like pretty closely matched in terms of the studies on them, but it does seem to be that excision has a bit of an edge if we can accomplish it. And these surgeries usually involve the surgeon being a little bit judicious about like, where are these lesions? Are they in sketchy areas? Is it safe to do excision here? Or should we usually do a combination of excision and ablation? Another good comment about surgery is that there are really kind of like two different broad categories of endometriosis surgeries. One is a type that many gynecologists do, which is where we will look in and see what we see and just figure out what's going on and treat superficial endometriosis. There is a second type of surgery, which usually occurs with an endometriosis specialist surgeon, and often in a very well-coordinated larger hospital setting where you have the gynecologist and a bowel surgeon and a bladder surgeon, where these are often patients who know they have endometriosis because they've already had a diagnostic surgery. They know they have bad endometriosis that's infiltrating their colon, their bladder, they have bad disease. And that surgeon and that patient are agreeing to go in and remove all of it, no matter what. Within the realm of safety, no matter what. So if that involves removing part of your colon and resecting part of your colon and reconnecting it in order to get it all, we're going to do that. Or if we need to remove part of your bladder and then stitch your bladder back up, that's going to be the plan. So that sounds like a lot, and that is not what occurs for everyone right off the bat at all. But that is what aggressive endometriosis surgery can be like sometimes. But that is not, I don't want any message there to be that's what's going to happen right off the bat. When you're trying to figure this out for the first time, the plan is to have a safe diagnostic surgery where you safely treat all the endometriosis that you can find. And that is very, very appropriate, essentially for everyone as a first step. And then one last point to touch on, and patients appropriately ask about this a lot, is do I need to have my uterus out? Do I need to remove my ovaries as part of this surgery? And one answer is you definitely do not. And most upfront surgeries to figure this out are not planned to be hysterectomies or removing ovaries. That is almost never what we're doing up front. This is another idea that for patients who really have bad recurrent disease, and we've usually had a first surgery, we know what we're up against, and we're still trying to win. There definitely is evidence that removing the uterus and removing the ovaries can have better and better effects on the disease. You can imagine if our medical treatments involve suppressing your estrogen levels, it's true that removing your ovaries is going to have a dramatic impact on your estrogen levels. So how effective are these surgeries? Pain relief, defined kind of broadly in this study, was approximately 75% of patients who underwent laparoscopic surgery, they experienced significant pain relief. However, the risk of recurrence of the endometriosis is estimated to be as high as 40% in 10 years. And overall, approximately 20% of those patients will have surgery rather soon, again, within 2 years of their index surgery. However, when you talk to patients about their retrospective view of the whole experience, and I think these numbers are consistent with what I hear in clinic, in this study, 90% of patients agreed or strongly agreed that choosing surgery was the right decision for them ultimately, and that about the same percentage said they would choose surgery again. So that is what I hear from patients. The lifestyle is important, but only works to a certain degree, and medicines have their own side effects and only work to a certain degree. And surgery does not work perfectly, but it is an effective tool. We can remove endometriosis and knock this condition back to something quite minimal and start anew, and so they are effective. I don't want patients to leap too quickly into surgery or to be too fearful of surgery, because I think they are really very safe. They're extremely informational, and they can be effective in terms of treatment. And this is just some numbers about what I was referring to about the rate of a patient needing another surgery, so having recurrence or their pain is bad enough that they're going back in to do it again, in 4 situations. 1, just a laparoscopy and treating endometriosis. The 2-year rate of reoperation is 20%. That's kind of what we had in the previous slide. And in 7 years, that can be as high as 60%. So what happens when we remove the uterus but leave both ovaries? So dramatic reductions in both of those. That the 2-year reoperation rate drops down to 8, 7 years 22. Removing one ovary drops it down some. I think that's kind of funny data in there in this particular study, but indeed, for patients that really are looking for the solution, having a hysterectomy and removing both ovaries does lead to the lowest rate of reoperation in the following years. So it is effective in that way. And although this is, I think we'd all agree, not what we want for everyone right off the bat, but there is success to be had here. And it is important just to note for people when you talk about like the idea of removing your ovaries, it is true that we can use low dose kind of hormone replacement therapy to make it such that you don't have terrible menopause symptoms from that maneuver and that you don't have these health risks of removing your ovaries too early. So I'm going to conclude here. Sorry, we're running long as I tend to do, but just to summarize this, it is really important for patients to have more information and better doctors and more discussion about this in terms of recognizing endometriosis as a condition and maybe an explanation for people's symptoms. The next step is to work with a doctor you know and trust and that's smart to try to get as close to as you can to a correct diagnosis, whether that's kind of like empiric, presumptive, as we talked about, or if it's surgery. And then to have the treatments presented to you in their entirety that are the right ones for you, whether that extends from lifestyle to medicine to surgery, et cetera. So just for some concluding thoughts, endometriosis is indeed a devastating, tragic, chronic disease. It is majorly underdiagnosed and undertreated. There are conservative, safe places to start in terms of lifestyle interventions, which can have, I think, a subtle but absolutely real impact on the experience of endometriosis. And that past that, there are medical and surgical options which can put this condition into real remission, so that you can really get back to a normal life. So that's the message. Thanks very much for listening. That's my beautiful wife on the left and our little 1.5-year-old daughter Willow on the right. And we live on a very pretty alpaca farm in Lyons with pretty sunrises. So thank you guys for listening. Hopefully we can have some time for questions. And there is a last slide which will be included in the slides that has resources for places to get more information. So thank you.
Thank you very much for your thorough explanation of endometriosis. And we do have a few questions. We're going to try to sneak those in here and then wrap it up.
Sure.
So one is, are there negative long-term effects of hormonal birth control?
So when we talk about, a few different answers to that based on which type of birth control you're talking about. So combined traditional birth control pills that have estrogen and progesterone, I think it's fair to say those don't really have a true chronic negative consequence to them. There's a lot of nuance to that statement, but I think in a general way they really are safe. There is a risk of blood clots that occurs for anyone who's taking any estrogen in any form, including a birth control pill. And there's a lot of discussion about what chronically being on birth control pills does to, in subtle ways, to women in other ways in terms of their testosterone levels and a number of things. So birth control pills, I think it's a correct message to say that those are really safe to be on long term, and indeed we do that a lot. There are risks to some of these other medicines in terms of progesterone-only options and the other medicines that I mentioned that really suppress your estrogen levels. That is kind of a menopausal state, which comes along with some menopausal problems if you're on them long enough. So that has to do with decreasing bone density and issues like that. That I think the risk there is really low in reality and can be monitored and accounted for, but there are side effects and there are risks to long-term hormonal therapy.
Okay. What is the success rate of having children when the diagnosis is infertility?
Yeah. This is a very tough question to answer. All things fertility there's so many factors that go into fertility, even outside of endometriosis, that we can't kind of understand and control. And then to throw in something like endo and inflammation and immune dysregulation it makes a confusing problem even more confusing. So I know there's not a very straightforward answer to that question. What it is, I would just say in general, it is possible to have an experience where scar tissue is dealt with in a surgery and endometriosis is suppressed in a way for a period of time where it's allowed to chill out and kind of become less active, and patients can have success conceiving even naturally, certainly after that, if we've kind of been able to like control what we can control there. If that is not successful, or another place where people end up with endometriosis is unfortunately, but often with fertility specialists who are doing IVF. And it is a spot of hope, I guess, that REIs, reproductive endocrinologists and IVF specialists, are able to succeed here, where patients are not able to conceive naturally. So, eggs can be harvested and embryos can be created and then can be implanted in the uterus in a way that works, and patients can definitely get pregnant. With endometriosis, it happens spontaneously, but it happens a lot with help too. So I don't know the numbers, but the message is not that you cannot get pregnant and won't get pregnant.
One person here had successful pain relief because of the gas that was used during surgery that seemed to expand the uterus area or the abdomen area. Have they done studies on that?
Well, they have, in a way. They're because we don't understand this disease perfectly, and because that study I referenced, where even if we do nothing, some disease gets worse, some stays the same, some gets better. There are factors here that we don't understand about why someone's disease or experience or symptoms get better. There is a placebo effect, and I'm not suggesting that that's all fake and in your head, because that's not what I mean by that. But there is that. There is the acknowledged, this is true in the data, that people have a diagnostic laparoscopy where very little was done, or maybe nothing was done, and they do experience an improvement in their pain, which is essentially exactly what this patient is describing. And I do not know the answer to that about why that would occur. You're correct in asking that. One of the few things that happened in that surgery was that someone went to sleep and their belly was expanded with gas, and we looked around and then we were done. So there's not really a mechanism for why that might be true that I can hazard a guess at, but it is a real phenomenon.
So another person found success with pain relief by green juice fasting with water enemas. Do you have any feedback on that?
I think there are a million ways to accomplish the principles that I was kind of describing in that lifestyle slide. We want to decrease inflammation in the body. We want to nourish the body, and bodies, humans that are deficient in certain things that green juice provides, or that are used to taking in foods and other things that inflame them, in a way that a green juice fast is essentially, I'm not against that, sounds fine to me. It doesn't sound fun to me, but it sounds fine. That is an elimination diet of sorts, we must admit that. And so whether the success is due to the green juice and the antioxidants and the good stuff that's in the green juice, or whether it's the avoidance of things that used to be in your diet before the cleanse, which is any number of gluten or other things that you're reacting to. I think when various dietary strategies work, the answer is somewhere in all that. And the important thing is that it works. So
we're going to probably get in another 2 or 3 and then wrap this up.
Sure.
Is it better to avoid the synthetic estrogen and the birth control pill and opt for a progesterone-only pill to manage the pain?
You know, there's no data to suggest that synthetic estrogens are tied to worse outcomes or experiences here. So I'd like to have less synthetic things in my body too. But I do think that the estrogens that are available in these combination birth control pills, I do think are safe and effective for this. And it is true that both combination birth control pills, which have both, and progesterone-only options, they are both effective at treating endometriosis pain for sure. I will tell you that I think the experience for the patient in terms of side effects is better. They're both options and they're both fine, but I think the experience is better for patients who are taking the combination birth control pill to get estrogen and progesterone. You know, these have a balancing relationship that we spent some time talking about there, that I think women I wouldn't say they have a terrible experience with progesterone only options, but I think they feel better when they're taking both estrogen and progesterone. So I think they're pretty close to equally effective. The studies that pit them against one another are really quite close. But I think experientially, the combination, including the estrogen, I think is better tolerated by patients, I think.
Okay. You touched a little bit on this. Is endometriosis hereditary?
Yeah, the answer is yes to that. I mean, it's not the entire story, but you know, there are some conditions where we can't really find any genetic linking, and there are some where it's quite clear. And I would say this one is quite clear. You know, whether it's twin studies, which are probably a little bit confusing to think about in a way, but those are very suggestive of hereditary links in endometriosis. The fact that we have identified some genes that are driving endometriosis obviously gets us into a genetic conversation, which can be hereditarily linked. So, my experience of talking to patients about like, oh, did your mom have this? Yeah, she did have this, and my sister has terrible periods too. Like, I do think it's real.
Okay. And you also spoke to this, but can endometriosis recur after surgery? I think you may have given a percentage.
It definitely can, and that's kind of like that. It's suggested in some of those studies that I cited about reoperation, right? So like the idea is that no one's hopping back into a surgery for another reason, is that their disease has recurred. So yeah, it is a true statement that anytime we're doing an endometriosis surgery, anytime that I can see and remove everything that I can see. But I know that I can't see everything. Endometriosis is a microscopic disease that grows very slowly. And so the surgeon, I should really never be saying like, we got it all, you know, because that's really never going to be true or known to be true. And so even after a really great surgery, almost everyone is going to have some endometriosis that's either still present or kind of new endometriosis that can arise later if they know they can develop this. So after any surgery, there needs to be a discussion about suppression afterwards. And you know, if that fact is true that you still have some endo in there, we either choose to not use suppression and see which third you're in there, and wait for symptoms to come back, hopefully never, but maybe, and then decide what to do. Or we choose to use suppression, that someone has a surgery, and then we choose to put them on a birth control pill right after surgery and keep, you know, we've knocked the disease back to something really small, and then we keep it suppressed. And you know, I think you can hear me say that there are different approaches to this. There's some where we just try a good treatment and see how we do. There's others, and these are often patients that have been locked in this battle for a long time, where they are going to chase down a strategy where they knock this down and they keep it down for as long as they can. So yeah, suppression is part of that knock it down, keep it down strategy.
Okay, thank you very much.